Hi, Dr. Brian Kaufman here at ASCO 2014. A doctor turned patient with CLL, and I'm with my friend Dr. Jeff Sharman. Dr. Sharman's had a number of poster presentations. Dr. Sharman, you want to introduce yourself?
Hi, it's a pleasure to see you again, and this isn't video, but we'll do this on audio, and it's great to have you, Brian.
Thanks, Dr. Sharman. One of the things that really interested me was a poster that you presented, were one of the co-authors on Obinituzumab, which is a third-generation monoclonal antibody. Can you kind of walk us through, first, what the drug is, and second, what the trial showed us?
You bet, Brian. So Obinituzumab is an anti-CD20 antibody. CD20 antibodies are very commonly used in almost all lymphomas and leukemias of B-cell origin, and really all CLL is going to be a B-cell disorder. So we've been using rituximab for quite a few years. That's been available commercially since about the year 2001, and has been actually a drug that showed a survival benefit when combined with fludarabine cyclophosphamide in the frontline therapy. So rituximab's been around a long time, very commonly used, and over the years people have tried to build a better mousetrap. And to that end, Obinituzumab, which is one CD20 antibody, has been approved by the FDA and it's been available for a handful of years. It doesn't have the most high degree of utilization in North America. And now Obinituzumab, which is also called Gazyva, and in a lot of the clinical trial literature is listed as GA101, is a new antibody that's been modified in a number of ways. Those modifications include a change in the way that it binds to the outside of the cancer cells, a more flexible business end so it can engage the immune system a little more effectively, and it's what's called a type 2 antibody, so that literally just this thing binding to the outside of the cancer cell kills it by mechanisms that aren't totally understood just yet.
So first I have to just say I love when you said building a better mousetrap, because patients often call rituximab mouse juice, because it's not a fully humanized, because I think its origins were from a mouse, murine. So tell us about the data. This was a monotherapy with an antibody, which usually is a pretty wimpy kind of response you get. And what were the responses like with this particular monoclonal antibody?
Yeah, so this was a randomized study in which patients received either 1,000 or 2,000 milligrams of Obinituzumab. Now, the reason we did this study is the following. So the Germans did the CLL11 study, which was a 3-arm study in which chlorambucil was compared to chlorambucil rituxan and chlorambucil Gazyva. And what that study showed is that rituxan absolutely beats chlorambucil in combination. So the combination of chlorambucil and rituxan is better than chlorambucil alone. But it was a 3-arm study, and so the group of patients that got chlorambucil Gazyva not only did better than the patients who got chlorambucil alone, but actually did quite a bit better than the patients who got chlorambucil rituxan. So head-to-head, chlorambucil rituxan versus chlorambucil Gazyva, the Gazyva patients did better. And that's important because in North America, rituxan monotherapy is very commonly used to manage patients with CLL, which is actually surprising because the data for that really is lacking. But I think that it's a drug that many practicing clinicians are familiar with, are comfortable with using, and even though it really doesn't have the best data, it's commonly done. It's a conundrum that many of us sort of shake our heads at and wonder why rituximab is used in that context. And so recognizing that that's a market pattern of how patients are treated, and now that we have an antibody very similar to rituximab but is superior to rituximab, we wanted to know some more things about dosing and schedule and so forth.
So this new trial, 1,000 versus 2,000, that's per meter squared, is that correct?
So this is actually flat dosing, so there's no per meter squared. So frequently rituximab is administered at either 375 milligrams per meter squared or 500 milligrams per meter squared on subsequent dosages. take the average American, that's a dose of roughly 750 milligrams, maybe a little bit higher, maybe a little bit lower. So it's not a tremendous difference in the dose. But when you have somebody with CLL, they bind up all the CD20 antibodies, and so it's sometimes you have to give a good slug of the drug, of the antibody, to get adequate levels. And in fact, that one of the studies of rituximab monotherapy previously by Susan O'Brien looked at dose intensification of rituximab as a way to improve its efficacy in CLL. So here we are using a higher dose. 1,000 milligrams is a little bit higher than the typical dose, and 2,000 milligrams is higher than the FDA-approved dose. The FDA-approved dose is 1,000 milligrams in combination with chlorambucil. And so in this head-to-head study, what we saw was that there was actually a difference in response rate, although it did not achieve statistical significance. And ultimately, this is really more just kind of about understanding dose a little bit better. We weren't trying to demonstrate superiority. We were just trying to understand if there was a dose effect. And the progression-free survival, we in the 2,000 milligram arm, we have approximately 3/4 of patients still free from progression at about 18 months of follow-up.
What kind of response rates were you getting in terms of overall response rates, partial remissions, complete remissions? Can you share that with us?
The overall response rate was in the half to 2/3 range for both arms of the study. There were a number of patients who were evaluated outside of the treatment window, and so those were unable to be assessed. So it might be that if you just sort of got into the weeds, the response rate is a little bit better. But qualitatively, it is a very different drug than rituximab, and administering it is different as well. We do see a higher rate of infusion reactions when the drug is first given, and one of the things we learned in the study was that by splitting the dose, so patients get 100 milligrams on the first day, it makes it quite a bit more safe to do. But we also noted that oftentimes the infusion reaction, once it had happened, it was very infrequent that it reoccurred. So by giving just a little bit of the medication until somebody had some infusion reactions and gave them time to sort of cool off, we were able to give the remainder of the medication uneventfully.
Were there any other common or serious adverse events with this? Do we know enough about this to see the late onset neutropenia or some of the rare but serious infections you can get with other CD20s?
We did see neutropenia. It was well tolerated, though I wouldn't say that neutropenia was frequently a limitation. I should say in the positive, it was infrequently a limitation of the medication. I will tell you anecdotally, though, of one patient I treated who did have actually grade 4 cytopenias after just a few dosages. So he became anemic and his platelets were low. We actually transfused him, but he actually only got about 2 or 3 doses of the medication, and now he's out about 2 years and hasn't relapsed. So, I don't know if that was something of, really dynamic efficacy in him, and there was something else going on. But he's clearly got a very normal functioning marrow at this point. His marrow was free from disease. We actually did a marrow, and he had a CR in the marrow, even with just a few dosages. So it was quite a startling case.
Anything else that we should know about this medication and how you see it fitting in? It sounds like it would be likely used in combination with maybe with one of the new novel oral agents. Is that kind of where you see it fitting?
Yeah, so so it's approved for in combination with chlorambucil, and I think that there is a little bit of practice variation as to whether or not the drug is administered as a single agent or in combination with chlorambucil. Chlorambucil is a good drug that's been around for a long time and is quite safe to administer, and yet there does seem to be some chlorambucil phobia amongst many U.S. practicing oncologists that I think exceeds the reality of the medicine. So it is approved for combination therapy. But given that ibrutinib has a study currently comparing ibrutinib to chlorambucil, and it's likely that new biologic doublets will be forthcoming, I think that the future of chlorambucil will be likely to be completely eradicated from prescription patterns within the next few years.
All right, so let's take a quick break there, and then maybe we'll switch to some other novel therapies that are that you've done some research on.
Great.